Hi friends, welcome back to Joan Academy. In this video we shall look at the anatomy of the elbow joint, its articulating surfaces, movements performed at this joint, stability of this joint, and the clinical relevance of the joint. So, let's have fun! The elbow is the joint that connects the arm to the forearm. It is a hinge-type synovial joint. Let us look at some of the structures that make up this joint. The structures of this joint consist of the articulating surfaces of the joint, capsule of the joint, bursae, and ligaments of this joint. They are two articulating surfaces seen in the elbow joint. The first one is the one between the trochlear notch of the ulna and the trochlea of the humerus. The second articulating surface is the one between head of the radius and the capitulum of the humerus. Being a synovial joint, it has joint capsules, which are strong and fiber that cover the joint and also give strength to the joint. The joint capsule is thickened medially and laterally to form collateral ligaments, which stabilize the flexing and extending motion of the arm. There are also presence of bursa in the joint, which contains small amount of synovial fluid, which helps to decrease friction between tendons, bones, and skin during movement. Some of the bursa seen in this joint are intratendinous olecranon bursa, which is located within the tendon of the triceps brachii. The next bursa seen in this joint is the subtendinous olecranon bursa that is between the olecranon and the tendon of the triceps brachii. The work of this particular bursa is to reduce friction between the two structures during extension and flexion of the arm. Another bursa seen in this joint is subcutaneous olecranon bursa, which is between the olecranon and the overlying connective tissue. The ligaments seen in the elbow joint, which strengthen the joint capsule, are the radial collateral ligament and the ulnar collateral ligament. The radial collateral ligament is seen on the lateral side of the joint, extending from the lateral epicondyle and blending with the annular ligament of the radius. The annular ligament of the radius is the ligament from the proximal radio-ulnar joint. The ulnar collateral ligament, on the other hand, originates from the medial epicondyle and attaches to the coronoid process and olecranon of the ulna. Let's look at the blood supply to this joint. The elbow joint receives a rich arterial supply from a surrounding network of vessels, which is formed by branches of the brachial artery. As for the nerve supply, the elbow joint is innervated by branches of the medial, the musculocutaneous, the radial, and the ulnar nerves. We can see that the elbow joint receives nerve supply from almost all the major branches of the brachial plexus. There are some movements that are possible in this joint. The movements possible in this joint are extension and flexion movements, and the reason for these movements is that the orientation of the bones forming the elbow joint produces a hinge-type synovial joint. The extension movement is carried out by the triceps brachii and anconeus, while the flexion movement is carried out by the brachialis, the biceps brachii, and the brachioradialis muscle. It is important we note that pronation and supination do not happen at the elbow. Rather, they are produced at the nearby radio-ulnar joints. The clinical implications associated with the elbow joint include bursitis, dislocation, epicondylitis, and supracondylar fracture. Bursitis is the inflammation of the bursa due to repeated friction and pressure. The bursitis seen in the elbow joint is subcutaneous bursitis and subtendinous bursitis. Subcutaneous bursitis is caused by repeated friction and pressure on the bursa. Because the subcutaneous bursa lies superficially, it can also become infected by skin laceration from a fall on the elbow. The subtendinous bursitis is caused by repeated flexion and extension of the forearm, commonly seen in assembly line workers. Usually flexion is more painful as more pressure is put on the bursa. An elbow dislocation usually occurs when an individual falls on a hand with the elbow flexed, most especially in young children. In the dislocation of the elbow joint, the distal end of the humerus is driven through the weakest part of the joint capsule, which is the anterior side. The ulnar collateral ligament is usually torn, and there can also be ulnar nerve involvement. Most elbow dislocations are posterior, and it is important to note that elbow dislocations are named by the position of the ulna and radius, not the humerus. Epicondylitis is also known as tennis elbow or golfer's elbow. This is due to the fact that most of the flexor and extensor muscles in the forearm have a common tendinous origin, and the flexor muscles originate from the medial epicondyle. while the extensor muscles originate from the lateral epicondyle. Because of this, sportspersons can develop an overuse strain of the common tendon, which then brings about pain and inflammation around the area of the affected epicondyle. Typically, common tennis players experience pain in the lateral epicondyle from the common extensor origin. Golfers experience pain in the medial epicondyle from the common flexor origin. This is easily remembered as golfers aim for the middle of the fairway, while tennis players aim for the lateral line of the court. The supracondylar fracture usually occurs due to a fall onto an outstretched, extended hand in a child, but more rarely can occur by a direct impact onto a flexed elbow. It is a typical transverse fracture that spans between the two epicondyles in the relatively weak epicondylar region formed by the olecranon fossa and coronoid fossa, which lie opposite each other in the distal humerus. Direct damage or swelling can cause interference to the blood supply of the forearm via the brachial artery. The resulting ischemia can cause Volkmann's ischemic contracture, which is an uncontrolled flexion of the hand as flexor muscles become fibrotic and short. There can also be damage to the medial, ulnar or radial nerves. As a result, the neurovascular examination and documentation of all patients presenting with these injuries is important. Sometimes the blood supply can be interrupted acutely, leading to a pale, pulseless limb, often in a child, usually requiring emergency surgery. Friends, that is it on the anatomy of the elbow joint. I hope this video would be helpful enough. Don't forget to share this video and also subscribe to Joe Academy. See you next time.